So good afternoon, everybody. My name is Javier Cortés. I'm a breast cancer medical oncologist working in the beautiful city of Madrid and the second beautiful city of Barcelona, not as nicest as Madrid, in Spain. And very welcome to this educational session, Optimizing Early HER2-positive Breast Cancer Treatment. I think that when we are talking about when a patient comes to the clinic and you have the pathology report and you see that the patient has a HER2-positive breast cancer, we start to have like a smile in our mouth. Basically, if we compare with luminal B or with triple-negative breast cancer. But it is true that there are so many unanswered questions yet, and I hope that today, with this group of friends here, we will be able, I don't know if being able to answer all questions, certainly not, but at least to put some lights into the darkness. And my role here is to moderate and to be a little bit tricky. So I promise that I'm going to ask many tricky questions, just from the clinical perspective, okay? So can we really de-escalate in the clinical practice? Do we have to escalate always? TDM1 for all patients today, maybe tomorrow with other drugs which are upcoming. So do we have to use TILs in the clinical practice? What about HER2-DX? So we have many questions that maybe are not so easy to be answered. I think during this symposium, we'll have also many biomarker-based data that also might help us to understand how to optimize the treatment of our patients. So many, many, many questions that have not been answered yet. My mother had HER2-positive breast cancer last year, and I have treated her with the Fergen strategy without chemotherapy. She did not have PCR, and I gave TDM1 with no chemotherapy. She's 76-year-old, nevertheless. I'm doing things properly or not? She's my mother. It's not my mother-in-law. It's my mother. So I don't know, but, well, let's see. I hope yes. So certainly many, many questions. And for this purpose, we have 4 folks here. Let me introduce them first, because we will do all the lectures one after the other. And we have a lot of time for discussion afterwards. You are more than invited to submit questions via the web, or we have microphones here. You can go to the microphone and ask whatever you want. I always say the same. The worst English in the room is mine. So don't be shy. If we don't have a lot of questions, this is not a good event. This is the purpose of this meeting. So the first talk will be neoadjuvant management and adaptive strategies. And this will be given by Dr. Sonke from the Netherlands Cancer Institute in Amsterdam, in the Netherlands, Europe. Second, what about small tumors? T1A, T1B, T1C, can we de-escalate treatment always or not? So this will be given by Adrienne from the Dana-Farber Cancer Institute in Boston, Massachusetts, here in the US. And last but not least, the last lecture will be post-neoadjuvant treatment in patients who did not achieve pathological complete remission, always TDM1 or not. I think that many questions again. And it will be given by Joyce from the Baylor University Medical Cancer Center in Texas, very near from here. And last but not least, we have the privilege to be joined by Beth Emory, patient advocate. So thank you very, very much for being here and pick our brain a lot from your perspective. What are we doing badly or not? So help us to optimize the clinical trial design for the future, because sometimes we request many biopsies. Do we need so many biopsies? From your perspective, what are the things we are not doing in a perfect way? So again, very welcome you all. Thank you very much for being here. Enjoy the meeting, and please don't hesitate to ask all the questions you would like to ask. So let's start with the first speaker, Dr. Sonke from the Netherlands. Thank you very much. And thank you.
So thank you very much, Joyce, for the kind introduction, and thank you everybody for being here this afternoon. I'm going to talk about the neoadjuvant management and adaptive strategies in HER2-positive breast cancer. So my name is Gabe. I'm a medical oncologist from Amsterdam, Netherlands Cancer Institute. These are my disclosures. So HER2-positive breast cancer, as already said, is actually a success story. I think along the same lines as cisplatin for testicular cancer or Gleevec for GIST, immunotherapy now for melanoma. This is what we've seen in HER2-positive breast cancer over the decades. So this graph depicts a combination of totally different trials from two totally different eras. So So the black curve is a compilation of data from Bill McGuire's group, actually, in the 1980s. Node-positive, HER2-positive breast cancer showing only 35% disease-free survival after mostly local therapy alone. And the red curve is the longer-term survival data or disease-free survival data from the Neosphere study, reaching 85%. And this difference of 50% is really what we've been able to provide to our patients in the last 50 years. And this is, I think, why we're laughing when a patient has HER2-positive disease. And this is mostly due to the development of new drugs that target the Achilles heel of the HER2-positive breast cancer, the HER2 receptor. Firstly, mostly trastuzumab, and then later other drugs such as pertuzumab and lapatinib. Later also the ADCs, TDM1, TDXD. And I'm going to focus on the neoadjuvant treatment of stage 2 and 3 with using these drugs. So the stage 1 will be covered in the next talk, and the post-neoadjuvant treatment will also be covered in another talk. So why neoadjuvant in the first place? I think all of us know this very well, but it's still good to recapitulate why we're doing this. Because also for patients, it's my opinion that they don't really always know why we're giving treatment in a neoadjuvant setting, and it's always good to repeat and explain why we're doing this. So clearly one reason, which is a very obvious reason for patients, is that you have a reduction in tumor size, and allowing breast-conserving surgery, also reduction in axillary involvement, allowing axillary-sparing surgery, or no surgery of the axilla. But there's more reasons to give it in a neoadjuvant setting, and one is the treatment adaptation, or treatment monitoring and treatment adaptation that we can use in a neoadjuvant setting. And while this holds a great promise, I don't think that we're really using this to its full potential at this current moment, and I think these are really options for improving our treatment algorithms further. Early targeting of micrometastatic disease, it's always good to treat these cells at an early stage rather than wait for the surgery and radiotherapy to finish. If this is what kills first, then you need to treat it first. Guide adjuvant treatment decision. Again, this will be the topic of the talk by Dr. Shaughnessy. And then early endpoints of clinical trials. This is good for a regulatory perspective, so you can get drugs to the market faster if there is a good surrogacy for the early endpoints, mostly pathologic complete response. So this is data from 12 institutions across Europe and the United States, with about 750 HER2-positive, ER-positive patients and about 500 HER2-positive, ER-negative patients, showing that the amount of residual disease is clearly associated with longer-term outcome. What you can also see is that the RCB1, which is typically considered almost as good as a PCR, and RCB0, in fact, in HER2-positive disease, does not convey as good outcomes as does the RCB0. So striving for a complete pathologic remission or a PCR RCB0 is really something that we should aim for. RCB is increasingly used in clinical trials, and I think this is useful also for the post-neoadjuvant treatment decisions. So how did we get to our current standard of care practice? And I think once the trastuzumab was registered for the adjuvant phase based on the adjuvant trials, it was almost immediately also used in the neoadjuvant setting without particular studies solely focusing on a neoadjuvant setting. Actually, everything that was registered for the adjuvant setting was also translated into a neoadjuvant setting, which is different from today where we need separate studies for both settings. So the Neosphere study randomized into 4 groups, taxane-based, trastuzumab-based therapy with or without pertuzumab. And what you can see that after 4 cycles of combination therapy, pathologic complete response was about 15% higher with the addition of pertuzumab. What you can also see, and we'll come back a bit later, is that there's an arm without any chemotherapy, so trastuzumab alone, reaching about 17–18% pathologic complete response rates. And what you can also notice is that all patients in this trial received chemotherapy, adjuvant chemotherapy after surgery, and it was all anthracycline-based. Using all chemotherapy in the pre-surgery setting gives us more methods to adjust our therapy and also to use the PCR as a true endpoint, if it's not confounded by the adjuvant chemotherapy. And this is done in the Christine trial, where it's not just adding all or using all chemotherapy in the neoadjuvant setting, but also compared to the Neosphere study, increasing the number of cycles from 4 to 6 and also adding carboplatin. With this increased regimen, this more intensive regimen, you also see that the pathologic complete response rates increased compared to Neosphere to almost 70% in ER-negative patients and over 50% in ER-positive patients. And this also translated in a high event-free survival of almost 90%. The study compared TDM1 with a TCHP regimen, and the TDM1 regimen performed a bit less, not so much in the overall survival, but definitely in the PCR and the event-free survival. But both regimens were anthracycline-free regimens and doing very well. Now, this concept of anthracycline-free regimen was studied in several other studies, and I'm going to show you the results of the TRAIN2 study, which we performed in the Netherlands, which directly compared the regimen with and a regimen without anthracyclines. And what it showed is that the PCR rates and the event-free survival rates are exactly similar, but there's much more toxicity as expected with the anthracycline. Mostly cardiac toxicity and also secondary malignancies were higher in the anthracycline arm. And this is completely in line with other studies, the BCIC6 trial, which was done in the adjuvant setting, and also the Trifina trial in the neoadjuvant setting, all showing, in line also with Christine, that anthracycline-based therapy is something that is not needed in the HER2-positive space. It adds toxicity, but it does not add any benefit. So our current practice is a neoadjuvant taxane platinum-containing regimen with trastuzumab and pertuzumab, resulting in event-free survival rates of about 85 to even 95%. Anthracycline, cyclophosphamide do not add benefit, although they may be used for specific circumstances, such as patients who do not respond, patients with intratumoral heterogeneity, which we'll come back to a bit later, or patients who relapse after prior taxane therapy. So what about endocrine therapy in this setting? 8 years ago in this meeting, I was watching the result of the NSABP B52 trial, which actually compared the concurrent administration of estrogen deprivation to chemotherapy. So a randomized study, TCH, with or without estrogen deprivation, consisting of an AI and in premenopausal patients, also LH-RH agonist. And what they showed is that, maybe contrary to what we believe and what we thought of concurrent chemoendocrine therapy with tamoxifen suggesting an antagonistic effect, the results are similar, even a bit better, if you combine chemotherapy and endocrine therapy and targeted therapy. And maybe this has to do with a crosstalk between aromatase inhibitors and HER2 targeted agents. Surprisingly, the study, as far as I have found, was never published, and it's a pity that there's also a lot of translational work that patient contributed biopsies to has never been printed in a journal. And I think it's still useful and I think mandatory that this will be done. So what are key questions to address further for the future? So can we identify the 10% of patients who still relapse, and can we improve the efficacy for these patients? And conversely, can we reduce the treatment burden for the 90% of patients who are cured? So to identify the patients with relapse, there's a lot of biomarker study being performed. I'm going to give you an overview of selected biomarker studies. Of note, this is not truly prognostic factors because all these biomarkers are tested in a treated population. There's no watchful waiting or no patient without any systemic therapy. Still, if you see a very high response rate, then there might be a reason for de-escalating treatment or de-intensifying treatment in these patients. Whereas conversely, if there's a very small chance of response, there may be a reason to change therapy to another regimen. So for instance, the difference between HER2 3+ and HER2 2+ on IHC is strikingly different in terms of complete response rates. And similarly, the intratumoral heterogeneity, which I talked about before, if there is ITH, the chance of a pathologic complete response is much less. As you can imagine, if there are spots of tumor cells that do not express HER2, they're unlikely to respond to HER2-based therapies. Well, in addition to these fairly easily available pathologic, common conventional pathologic markers, there's a lot of molecular pathologic markers, which sometimes are combined with clinical characteristics as well, such as the ADEPT prognostic score and the HER2-DX PCR score. And all of these show a divergence in PCR rates between the various strata of these markers. And while I don't think that these are ready to be used in clinical practice, I think it is hugely important to have these in clinical trials to select patients that are eligible for intensified treatment or de-intensified treatment. And another marker is TILs, which is increasingly used in triple-negative breast cancer, whereas patients with high TILs have a very low chance of recurrence and may even spared any chemotherapy. If you look at the same thing in HER2-positive early breast cancer, you don't see a striking difference in the rate of PCR, as you see on the left side. But there is a difference in the rate of event-free survival, both in the short-HER trial, also in the TRAIN2 trial, with 50 to 60% as a cutoff use in these trials. So what you can also appreciate is that the relationship between PCR and longer-term endpoints may not be the same for all strata, or not for all biomarkers, and for that matter, even not for all treatments. We know, I think, from immunotherapy, which is not so much used, at least not the classic checkpoint inhibitors, the relationship between PCR and long-term survival is not as strong as it is with chemotherapy and anti-HER2 therapy. So one trial that uses biomarkers in the neoadjuvant setting, as a great example for that, is the Ariadne trial by my colleague Theo Foukakis and others in Karolinska in Sweden. And what they do is they randomize between TCHP and TDXD. And in the meantime, do a PAM50-based assay. And after 3 cycles, the follow-up treatment after 3 cycles depends on the result of the PAM50. As patients with an HER2-enriched tumor continue with the regimen they were randomized to. If there is a luminal ER-positive tumor, they go on to hormonal treatment with ribociclib, in addition to trastuzumab and pertuzumab. And if there's a Besa-like molecular subtype or an ER-negative luminal subtype, depending on the response on MRI, they change to an anthracycline-based therapy or continue with the TCHP or TDXD if they have a good response to begin with. So for me, this is a good example of how we should perform adaptive trials and use the molecular information that we have from the tumors to guide our trials. But there's other trials currently going on. So for instance, the WSG ADAPT trial, which also stratifies according to baseline risk of relapse, using TDXD or comparing TDXD to paclitaxel, trastuzumab, pertuzumab, and in high-risk patients also adding carboplatin. Another example of guided treatment, not just all comers giving the same treatment. Final study I'd like to mention is DESTINY-Breast11, for which we expect results next year maybe, which initially had 3 arms, a TDXD times 8 arm, a TDXD times 4 followed by THP, and an arm with AC times 4 followed by THP times 4. Based on recommendation of the IDMC, the monotherapy TDXD arm was closed prematurely, and we're now waiting for the results of both arms to hopefully be presented next year. Now, as I said, this study does not have an inclusion criteria based on any molecular or other biomarker. It's mostly trying to improve outcome for all patients. While this is in itself a good idea, I think given the fact that it's also increasing the number of cycles of treatment from 4 to 6 or even 8 in this trial, it's clear that there's also a lot of overtreatment in this study because we know that even 6 cycles or even 4 cycles of treatment can give high pathologic complete response rates and good event-free survival as well. I think one other point to note in these trials with TDXD, if this becomes a new standard of care, maybe in the future, it's less certain what the effect of the adjuvant TDM1 can be, because I think from the adjuvant or from the metastatic setting, there's suggestions that one ADC after the other is less effective. So what is the value of adjuvant TDM1 after TDXD in neoadjuvant setting? Now, instead of giving more chemotherapy, as in DESTINY-Breast11, there's also reasons to try and have less chemotherapy. So the TRAIN3 uses this example of MRI-based treatment optimization. So what we've done in this trial is to have 3 cycles of paclitaxel, carboplatin, trastuzumab, pertuzumab, and have repeat MRI after 3 cycles. And if there is a complete radiologic response, refer to surgery immediately. If there is an incomplete response, but still ongoing, you give another 3 cycles, and you repeat that after 6 cycles, so ultimately even going to 9 cycles in the absence of a radiologic complete response. So patient in this trial received either 3, 6, or 9 cycles of chemotherapy, depending on the MRI result. Now, the initial PCR results were presented at this symposium 2 years ago by Anna van der Voort, and it showed that 1/3 of the patient in both ER-positive and ER-negative subgroups have a radiologic complete response after 3 cycles of therapy. And in the ER-negative subgroup, MRI is very well able to identify the pathologic complete response as well, meaning that almost 90% of the patients with a radiologic response also have a pathologic complete response. In the ER-positive subgroup, the MRI is less accurate to predict the PCR rate, as the negative predictive value is only 50%. And I think additional measures, maybe using CTCs or repeat biopsies, will be needed to better, more accurately identify these patients. Tomorrow in the rapid fire session, my colleague Fleur Louis will present the 3-year event-free survival data of this trial, which is the primary endpoint. Now, train 3 is looking at less chemotherapy, 3, 6, 9 cycles. Can we omit chemotherapy altogether? So the Neosphere, I told you before, has a PCR rate of 17%, with trastuzumab pertuzumab alone for 4 cycles. The German ADAPT trial also did 4 cycles of trastuzumab pertuzumab, only in ER-negative patients this was, seeing 36% of patients reaching a PCR. The Paralyza study, 5 cycles of trastuzumab pertuzumab, resulting in 20% PCR rate. And this was in patients who had a Ki-67 response after 2 weeks of induction letrozole. Then the Forgain trial in PET responders, and we look a bit later at this trial, had 38% pathologic complete response after 8 cycles of trastuzumab pertuzumab. So clearly there's a group of very sensitive patients, or very sensitive tumors, I must say, that can be spared chemotherapy altogether. So looking a bit more at the Forgain study, which was initially published in Lancet Oncology with PCR results, and later this year the longer-term results in the Lancet. It actually randomized between a standard of care chemotherapy arm, arm A, and then an arm B, which started with the pertuzumab trastuzumab alone, added with letrozole in case of, or hormonal therapy in case of an ER-positive tumor. Then in case of a sufficient PET response after 2 cycles, patients continued with the same regimen up until 8 cycles, or changed to a chemotherapy regimen in case of insufficient PET response. And here you see the results both on PCR, but also importantly, the 3-year event-free survival in the arm that was randomized to start with pertuzumab trastuzumab alone is very high, with about 95% event-free survival rate. And notably, this includes the patients that started with the biologicals only and then were rescued with the chemotherapy, indicating that starting with de-intensified treatment and escalating based on imaging is a safe strategy. Now, it's interesting to see what is needed to implement these results in clinical practice. Similar design, similar data were used to implement the APT trial, also a single-arm trial based on with very high event-free survival rates. And I think the APT regimen is widely implemented in all of our practices. Now, this trial is not widely implemented, and it's interesting to think what we will need to implement results like these. Now, maybe one reason why this is not easily implemented is that PET scanning is not widely available, where this is done in this trial. Maybe that's one of the reasons that the Forgain 2 trial used MRI scanning instead of the PET. But apart from that, used a rather similar design looking at the pertuzumab trastuzumab alone arms. And enrollment has included, I was told, and we're waiting for the results and see what we will need to have this type of results, at least, or the type of strategies implemented. So what can a potential treatment algorithm in the future look like if you try to, at one side, maximize the efficacy of patients' treatment and at the same time optimizing quality of life and limit tolerability? So looking at stage 2 and 3 HER2-positive breast cancer, if you have an optimal patient selection based on, for instance, an HER2 3+ on IHC or high TILs or the absence of intratumoral heterogeneity, perhaps you can all treat these patients with a de-intensified, de-escalated regimen consisting of trastuzumab and pertuzumab alone. And then have an on-treatment response evaluation, be it with MRI scanning, be it with PET scanning if it's available, or maybe with CTCs or repeated tumor biopsies, whatever is most feasible. And those who respond well and are likely to achieve a PCR can continue with the de-intensified treatment, whereas those who do not can safely be rescued with the conventional or the standard of care chemotherapy without detrimenting or harming their outcome. Then, of course, there will be surgery, and the post-neoadjuvant treatment can be based on the results at surgery. Well, this can be done in clinical practice at some point. I think we need to think about what data we will need to implement such a strategy. It will be good for the discussion and the questions from the audience. It's also important to have trials like this in place if you do further neoadjuvant studies. And I think the new I-SPY 2.2 design is a perfect example of exactly this, what we were talking about. Looking at 3 blocks of treatments. First, a good patient screening with biomarkers. Then have a block A, which is a de-intensified regimen without chemotherapy, and those who have an excellent response can be referred for early surgery. Those who do not have a good response can be escalated to block B with a standard of care, possibly added with another investigational agent. Again, if there's a good response, patient can be referred for surgery or continue the treatment, and those who still do not respond can continue to block C, which is a rescue regimen. And then, of course, surgery will follow. I think treatment or study algorithms like that, adaptive study algorithms like this, is the way forward to learn as much as possible from the patients and from the treatments and advance science as quickly as possible. Some optimization trials in HER2-positive disease that are currently ongoing. Some, the COMPASS-2 and the DiCrescendo, are mostly also looking at the post-adjuvant trial setting, so I will not go into that too much. The FAGAIN-2 trial I already alluded to. And the TRAIN-4 trial, which we're doing now, is trastuzumab, pertuzumab with another anti-HER2 agent, tucatinib, in the neoadjuvant setting, and we'll see the results of that hopefully next year. So in summary, the neoadjuvant approach is standard of care for stage 2 and 3 HER2-positive breast cancer. A taxane platinum plus trastuzumab, pertuzumab regimen is preferred. Anthracyclines, in my opinion, have no place as a standard of care. Baseline AHC and molecular markers are associated with outcome and can be used mostly in trials and hopefully in the future also in clinical practice. MRI and also PET scan can identify early complete responders, which can be used in the treatment algorithms as well. Adaptive treatment algorithms may help to maximize both efficacy and quality of life, and adaptive trial designs may help to advance the new trial developments. And with that, I'd like to thank you for your attention and take your questions afterwards.
Thanks very much, Gabe. We'll have the questions afterwards at the end. So, Adrienne.
Good afternoon, everybody. I'm Ada Wax from Dana-Farber Cancer Institute. I'm happy to be doing the second talk of the session, and I'll talk about the treatment of small HER2-positive tumors in the early stage setting, essentially stage 1 HER2-positive breast cancer. These are my disclosures. So here are the questions I'll try to go through for us in the next 25 minutes or so. First, briefly, what are our current guidelines and practice patterns for stage 1 HER2-positive breast cancer? And sorry, but this is pretty much a US-based answer here. What are the treatment regimens that we have for stage 1 HER2-positive breast cancer? What features help us predict who will recur following their treatment for a stage 1 tumor? A common clinical question I think we come against, which is, should any patients with a clinical stage 1 tumor be treated in the neoadjuvant setting? What about giving these patients HER2-directed therapy without chemotherapy, which we just heard some great discussion of? And which of these patients should receive absolutely no systemic therapy for a low-risk small tumor? So, what are the current guidelines and practice patterns, at least here in the United States? So here are the 2024 NCCN guidelines for stage 1 HER2-positive breast cancer. Hormone receptor-positive patient guidelines are on the top. The hormone receptor-negative HER2-positive guidelines are on the bottom. And as you can see, the guidelines come down clearly and definitively and helpfully that for patients with a pathologic T1C node-negative cancer, we should give that patient adjuvant trastuzumab with chemotherapy. But in the PT1A and the PT1B tumor sizes, so patients with tumors less than or equal to a centimeter that are node negative, regardless of whether that patient is hormone receptor positive or hormone receptor negative, the guidelines don't give us any helpful guidance here. They use the word consider multiple times, and we don't have a definitive recommendation about whether we should administer agents like chemo and trastuzumab to these patients. So over the course of the talk, we'll try to look a little bit more into the data and the limitations of the data for those particularly small tumors. Because of the lack of definition of those NCCN guidelines, we were interested in looking across the United States just at what are the practice patterns that are implemented for these particularly small tumors. This is an analysis we did in the population-based United States SEER database, looking from the years of 2010 to 2019 for patients with stage 1 HER2-positive breast cancer, just to see what proportion of patients nationwide were being treated with adjuvant chemotherapy. And the rates of chemo treatment are summarized on the bottom there for patients with PT1 microscopic N0 tumors. 12 to 14% of those were receiving adjuvant chemo. In the PT1A size range, it was 30 to 40%, PT1B 60 to 70%, and PT1C 70 to 80%. So understandable heterogeneity in the decisions that patients and their doctors are making here, again, given a lack of definitive guidance in guidelines and in the data we have available. So what are the treatment regimens that we have for patients with stage 1 HER2-positive breast cancer? As was already alluded to, by far the best established regimen here is the APT trial regimen, or TH. The APT trial enrolled patients with early-stage HER2-positive breast cancer, all of whom were node negative, mostly stage 1, but actually allowed patients with tumor sizes in the range of 2 to 3 centimeters, so small stage 2 tumors were allowed here. And in a single-arm design, all of the patients got weekly paclitaxel for 12 weeks and trastuzumab for a year. About half of the patients enrolled in this trial were in the size range of greater than 1 centimeter. And again, you can see that 9% of the overall patient population, which was just 36 patients, did have tumors that were in the early stage 2 size range of 2 to 3 centimeters. And 2/3 of these patients were hormone receptor positive. We see over and over again that the majority of patients with a stage 1 HER2-positive tumor are also hormone receptor positive. So we've seen presented and published the final 10-year outcomes for this trial, which are shown here. There was an excellent 10-year recurrence-free interval of 96%, and what that translated to specifically in this cohort of 400 patients was 6 local regional recurrences and 6 distant recurrences, again in 400 patients over the course of 10 years. So really excellent outcomes here. I'm going to talk about recurrence-free interval a lot in this talk, so I just wanted to pause and remind us what are the events that go into recurrence-free interval. It's not a terribly common endpoint. An RFI event is either an invasive local regional breast cancer recurrence, a distant breast cancer recurrence, or a death related to breast cancer. That's a more circumscribed definition than disease-free survival, which includes those events, but also includes a contralateral invasive breast cancer and a death from a non-breast cancer cause. So you'll hear me refer a lot to RFI events in this talk. Investigators from the FDA subsequently did a follow-up analysis that I think further boosts our confidence in the APT trial results and the fact that the TH regimen really is adequate and curative treatment for stage 1 HER2-positive tumors. What these investigators did was that they used patient-level data from 5 of the randomized controlled trials that were used to support the original adjuvant trastuzumab approval. And they identified patients in those trials who met the APT eligibility criteria. Then they used propensity score matching to compare the IDFS at 3 to 5 years for those patients with the APT trial outcomes. And what they showed was that for the comparison of patients who got TH in the APT trial versus either ACTH or TCH in the original adjuvant trastuzumab trials, you can see these curves were really overlapping for both IDFS and overall survival. And for, I think, an interesting comparison of patients who got, again, the APT regimen of TH in the APT trial versus the multi-chemo regimen, but with no HER2-directed therapy of ACT in those original adjuvant trastuzumab trials, there was a clear superiority of the TH regimen in terms of both IDFS and overall survival. So building on the efficacy of that TH regimen, but the fact that, as we all know, 12 weeks of paclitaxel is still a toxic therapy, there was then the ATTEMPT trial, which looked at 1 year of adjuvant TDM1 for stage 1 HER2-positive patients. This is essentially the same as the APT population, except that this and all subsequent trials took out those early stage 2 tumors. So this is really only a purely stage 1 population. And these patients were randomized to TDM1 for the majority of patients versus for a full year versus a control arm of that TH regimen. And importantly, this trial design had the control arm only for purposes of a toxicity comparison, which I'll show you, and not for purposes of an efficacy comparison. Patients who were enrolled in this trial, very similar to the APT trial, exactly 50% were in the T1C size range, and 75% were also hormone receptor positive. These are the initial results that were presented from the ATTEMPT trial. The trial met its first co-primary objective, which was that it showed excellent 3-year invasive disease-free survival for the patients who were treated on the TDM1 arm, 3-year IDFS of 98%, 3-year recurrence-free interval of 99% for the almost 400 patients who got the TDM1. But the trial didn't meet its second co-primary objective, which was to compare the incidence of clinically relevant toxicities between the arms. The hypothesis had been that the year of TDM1 would look more tolerable than the TH regimen, and that didn't turn out to be true, at least in the way that it was defined in this trial, and I'll dive into that in one slide. But we've also seen now published and presented the 5-year outcomes from this trial, showing still very reassuringly really good 5-year recurrence-free interval of 98% at this most recent follow-up for the TDM1 arm of the trial. So let's talk in a little bit more detail about the tolerability of this 1 year of TDM1. Again, a second co-primary endpoint of the ATTEMPT trial was to compare the clinically relevant toxicity between the year of TDM1 and that standard TH regimen. And clinically relevant toxicity here was a customized definition specifically for this trial. These were the parameters that went into it. You can see that for many of them, actually, the TDM1 and the TH looked pretty equivalent in terms of outcomes. I'll highlight the neurotoxicity, grade 2 or above, was lower for the TDM1 arm. And then the likelihood of any toxicity requiring early discontinuation of the regimen was numerically quite a bit higher for the TDM1 arm, probably reflecting the fact that actually a year of TDM1 isn't that early to complete, whereas the paclitaxel, while it might be difficult to tolerate, only lasts for 12 weeks. So in the end, as you can see in that bottom gray bar, these two regimens actually were completely the same in terms of clinically relevant toxicity defined, at least in this way. There have, however, been a number of follow-up efforts to try to get at other ways of really understanding the patient experience and how it might differ between these two regimens. So you can see on the left side there a patient-reported outcome looking at overall quality of life measured by the FACT-B questionnaire. And you can see that the patients receiving TDM1 are tracking in that bluish purple line above the TH patients at all time points on the ATTEMPT trial. But you can also see, and it throws this data into some question, that that was even true at baseline before the patients had even begun their treatment, which I think just reflects the fact that the patient who got randomized to TDM1 felt happier with their randomization, and then that sort of was consistent throughout the duration of their treatment. But not surprisingly and importantly, rates of alopecia were lower on the TDM1 arm, significantly lower at the 3-week, the 12-week, and the 6-month time points, which is shown on the right there. And looking at chemotherapy-related amenorrhea, which is a really important endpoint for our premenopausal patients, that was significantly lower with the year of TDM1 compared to the TH regimen, and that's what's shown here. If you looked at the ATTEMPT trial patient subset who were premenopausal at baseline and looked at 18 months at what proportion of them had had resumption of their menses, that proportion was about half, 47% for those patients who got the TH regimen, and it was higher, 75% for the patients who got the TDM1 regimen. So I think that that is a really important result for our premenopausal patients. And again, building on the efficacy success of that full year of TDM1, but the disappointing results in terms of the trial-defined tolerability endpoint, we are now currently enrolling the ATTEMPT 2.0 trial, which is looking at a shorter course of adjuvant TDM1. This is the exact same patient population. Patients, again, are randomized 3-to-1, where 3/4 of the patients get TDM1, but only for 6 cycles, followed by sub-Q trastuzumab to complete 1 year, and again with that same control arm of TH, which is only there for a pre-specified toxicity comparison, not an efficacy comparison. So to conclude this first portion, the APT regimen is certainly the most standard approach for treating patients with stage 1 HER2-positive tumors in the adjuvant setting. However, the ATTEMPT regimen, that full year of TDM1, may have advantages in terms of less neuropathy, less alopecia, and less permanent amenorrhea for our premenopausal patients. And the ongoing ATTEMPT 2.0 trial will establish whether 6 cycles of TDM1 is sufficient to maintain those excellent cure rates and hopefully also better tolerated than the full year of TDM1 therapy. Okay, so what about which features will help us predict who will recur following treatment for a stage 1 HER2-positive breast cancer? So the APT and ATTEMPT trial investigators did a lot of work to try to look at tumor features and biomarkers that might predict RFI events in both of these trial populations, and these have been published as well. There are a number of important caveats here. As I showed you, there was an extremely small number of RFI events in both of these trials, and therefore these are very underpowered analyses. These are also all retrospective and post hoc analyses, so all of these data have to be taken with a grain of salt. With that being said, in these two populations, tumor size did not correlate with RFI events in either the APT or ATTEMPT trials. Hormone receptor status did not correlate with RFI events in either trial. TILs did not correlate with RFI events where it was looked at in the APT trial. The strength of HER2 IHC expression didn't correlate with RFI events in ATTEMPT. And interestingly, the only biomarker that did correlate with RFI events in both trials was the HER2-DX genomic risk score. About 5% of patients in both trials were classified as HER2-DX high risk for the risk score, and those patients did seem to have a significantly higher risk of an RFI event. But there are some limitations to that conclusion. One important one is that a different optimal cutoff for who was defined as HER2-DX high risk versus low risk needed to be applied in the two different trial populations. Also, again, these were retrospective analyses that were done in only a portion of the overall trial population. So I definitely think that the HER2-DX risk score finding is an interesting result, but also needs further validation. So to conclude here, again, any biomarker analysis that we do in a stage 1 HER2-positive population is going to be limited by a very small number of events. And to echo something that Dr. Sonke brought up as well, all of those analyses that I just showed were among patients who received treatment for their cancer. We have, to my knowledge, absolutely no data for any prognostic biomarker for any untreated patients, which would certainly be really nice to have. But with those important caveats, none of the tumor features that I showed, except the HER2-DX risk score, looked to correlate with an RFI event in this stage 1 population. Okay, what about, again, I think a really common clinical question that comes up, should any patients with a clinical stage 1 tumor be treated in the neoadjuvant setting? This basically comes up for our clinical T1C and 0 patients. I think there are very valid arguments on both sides of this debate. And spoiler alert, I'm not going to give you a hard and fast answer to this question. But in favor of upfront surgery is the fact that what I just showed you, in the APT and ATTEMPT trials, the 5 to 10-year RFI rates of 96 to 98% really tell us that we can effectively treat the majority of these patients with a much less toxic regimen. And again, T1C patients were very well represented in both of those trial populations. On the flip side, in favor of upfront surgery, clinical T1C and 0 patients were eligible for the Quiron trial, based on which we give adjuvant TDM1 for patients with residual disease, and it's associated, we saw, with an overall survival benefit. Clinical T1AB and 0 patients were not eligible for Quiron. And I think also really compellingly, pathologic nodal disease is found at surgery in a large proportion of our clinical T1C and 0 HER2-positive patients, and this is worrisome. Here's the results of our single institution experience looking at how often this occurs at Dana-Farber. We looked at all of the patients with stage 1 HER2-positive tumors who were clinically node negative, who went to upfront surgery. And for those patients who had a clinical category T1C tumor size and were clinically node negative, there was a 25% rate of pathologic nodal positivity at surgery, which is a concerning and high rate. So I think the way that the balance works out is this. If we take all of these patients to upfront surgery, then we're risking undertreatment for that proportion of patients who turn out to be pathologically node positive. However, If we do upfront systemic therapy for these patients, then we know that we are certainly overtreating all of those who could have had an excellent long-term outcome using a regimen like the ones I just showed you, the TH or the ATTEMPT regimen. And so I don't, again, have a conclusion slide here because I don't think that there's a one-size-fits-all management strategy for this particular clinical question. But what I can certainly say as a key takeaway is that if you're going to take one of these clinical T1CN0 HER2 positive patients for upfront surgery, which I certainly think is appropriate for many of these patients, then there's a key role for very comprehensive upfront axillary staging before you do that. So what about giving HER2-directed therapy without the chemotherapy for stage 1 tumors? So we just saw the results of the FERGAIN trial, and I think that there are basically two really good prospective cohorts that help us get at this question of how do HER2-directed regimens perform when we give absolutely no chemotherapy. You saw there are a number of experiences where we give this regimen, these agents alone in the neoadjuvant setting, but then in most of those trials, they then went on to get additional chemotherapy in the adjuvant setting. So I'm focusing here on patients who, in both the neoadjuvant and the adjuvant setting, in a prospective fashion, only got HER2-directed therapy. So we already heard about the FERGAIN trial. Importantly, this was not a stage 1 trial. About 90% of the patients in this trial actually had stage 2 or stage 3 HER2-positive tumors. And it was a complex design, which thankfully you already saw diagrammed. But I'm going to highlight just this one group. And basically, for these 86 patients, they received neoadjuvant HP, and then they went on to receive adjuvant HP over the course of 1 full year, and they didn't get any chemotherapy, and this was pre-specified per protocol, both preoperatively and postoperatively, for their early-stage HER2-positive breast cancer. And in these 86 patients, there was a very nice 3-year invasive disease-free survival rate of 96%, and that corresponded to only 1 ipsilateral breast cancer recurrence. But an important thing here to remember is that the group that I'm showing here had not just 1, but 2 points of selection for treatment sensitivity. First, they had to have a favorable early PET response after 2 cycles of neoadjuvant HP, and then second, they had to have a PCR at surgery. To contrast with that, I think this is a really interesting trial that was done by investigators in Japan, looking at adjuvant trastuzumab with or without chemotherapy in HER2-positive early breast cancer. They managed to enroll patients who were specifically aged 70 to 80 years old. All of these patients underwent upfront surgery for their HER2-positive early breast cancer, so this was purely an adjuvant trial. And those patients were then randomized to trastuzumab alone for a year or chemo plus trastuzumab for a year. The primary endpoint was disease-free survival, and this was a non-inferiority design. This is the enrolled population. So again, this was not a dedicated stage 1 trial. Actually, less than half of the patients in the trial had stage 1 tumors. Almost 20% of the patients in the trial had node-positive tumors, and only half of the patients were hormone receptor positive. So this was not a particularly low-risk group. These are the results of the trial. So the 3-year disease-free survival was 90% in the trastuzumab monotherapy arm, that's the red line there, versus 94% in the trastuzumab plus chemotherapy arm. That's a hazard ratio of 1.36, and you can see a really wide confidence interval around that hazard ratio. So at the end of the day, they concluded that non-inferiority was not met. There was potential addition of DFS benefit here with the chemotherapy, but importantly, this trial was underpowered due to lower than expected DFS events in both arms, and that's reflected again in that broad confidence interval. No surprise, there were fewer adverse events, and there was less deterioration in health-related quality of life if you didn't get the chemotherapy here. We're in the process of enrolling a 3rd cohort on this clinical trial of biologic-only treatment for a dedicated stage 1 HER2-positive population. This is the ADEPT trial. On this trial, patients with HER2-positive stage 1 disease who are also hormone receptor positive all are treated with sub-Q trastuzumab and pertuzumab for 1 full year and endocrine therapy of the physician's choice for at least 5 years. So to conclude here, I think, as you already heard, prospective data from the FERGAIN trial show us excellent 3-year outcomes with doublet HER2 blockade alone for carefully selected patients. Prospective data from that Japanese trial show a modest benefit of adding chemo to trastuzumab for unselected patients. There have been a number of efforts to try to look retrospectively at large data sets to further tease out the efficacy difference of trastuzumab plus or minus chemotherapy. I haven't shown those here, though, because I think that retrospective data have quite limited utility for evaluating outcomes with trastuzumab alone, given the enormous selection bias that would have gone into selecting a non-standard regimen for that patient. And the ongoing ADEPT trial that I showed you is prospectively evaluating a chemotherapy-sparing regimen in this large stage 1 cohort. And so to wrap up, which of our patients should receive no systemic therapy for their stage 1 HER2-positive breast cancer, aside from endocrine therapy if they're hormone receptor positive? So again, a number of retrospective cohort studies have been done to try to estimate outcomes for patients with stage 1 HER2-positive breast cancer who are not treated with either chemo or trastuzumab. And I tried to make a table here that, to my knowledge, has all of the cohorts that meet a couple of criteria. I only included cohorts where there were at least 50 patients involved, where there were outcomes available at a minimum of 5 years, and where there were breast cancer recurrence outcomes available, not just survival outcomes. So the top portion of the table here is cohorts that looked at the full range of stage 1 HER2-positive tumor sizes, PT1A, B, and C. And you can see in the rightmost column here that the distant disease-free survival estimates for these cohorts at 10 years hover right around 75%. So 25% of patients in these small sample sizes were experiencing a distant metastatic recurrence event by the 10-year mark, which I think is a worrisomely high proportion. In the bottom portion of the table, these are cohorts that enrolled just patients with tumors in the PT1A or PT1B size range, so less than or equal to a centimeter tumor size. You can see in the middle column here a pretty broad range of recurrence estimates. These are at the 5-year mark, from a low of 86% in the MD Anderson cohort up to a high of 97% in the cohort out of Kaiser Permanente. I think that's quite a broad range, and it's hard to know exactly how to present that when you're facing an individual patient in clinic, but those are the limited data that we have. So to conclude here, I think we see that with no chemo and no HER2-directed therapy for patients with a stage 1 HER2-positive cancer across the entire size spectrum, the risk of distant recurrence at 10 years looks to be between 20 and 30%, which is quite high. For patients with PT1AB HER2-positive tumors, less than or equal to a centimeter, the data show that the risk of distant recurrence at 5 years is between 3 and 14%. Again, I think a troublesomely broad range, but those are the data that we have. So for me, what this boils down to is that for PT1C tumors, the NCCN guidelines and the data support the fact that there's really no controversy. All of these should be treated, assuming a patient is fit. For PT1B tumors, I would lean certainly towards treating all of these, but with a stage 1 specific regimen. And for PT1A tumors, this is really an area of uncertainty and a good context for shared decision-making with our patients. And that's all. Thank you.
Good afternoon, everyone. Very glad to be here. Some excellent talks we've had here today in this very important topic for this highly curable group of patients. I'm Joyce O'Shaughnessy from Baylor University Medical Center, Texas Oncology and SCRI Network in Dallas, Texas. I want to thank Sarah Tolaney for sharing some of the slides you'll be seeing here. And I'll be focusing on the patient, the higher risk patient who is a non-pCR. What are some of our treatment strategies now and then going forward for these patients following post-neoadjuvant therapy? Here are my disclosures here. So as we have already seen from this very large meta-analysis of patients treated preoperatively with cytotoxic therapy, but also in combination with anti-HER2 directed therapy, we see on the left the HR positive patients and on the right the HR negative patients. And we can see that the patients who are RCB0 do quite well in the darker blue. And as has been pointed out, the RCB1 patients don't do as well as they do, for example, in triple-negative breast cancer. But the RCB2 and 3 patients do fairly poorly. We'll look at the ER-positive, HER2-positive patients on the right who are RCB3, and they have a very high risk of recurrence even by 2 to 3 years. I say that because this is a group we clearly want to use all of the tools we have at hand, and I would argue the same is true for the RCB2 patients as well. It's similar in the ER-negative, HER2-positive patients. The RCB3 patients don't do quite as poorly, but you can see there's still quite a lot of risk left in these patients after chemotherapy and HER2-directed therapy. Another way to look at this is to look at the outcome 3 to 5 year invasive disease-free survival here in these 5 neoadjuvant trials. The treatments you can see up at the top, chemotherapy with trastuzumab, and then it's a plus minus. The next 3 in the middle are plus minus lapatinib, and down the bottom is a plus minus pertuzumab. And you can see again in the non-pCR patients that still between, there's the 3 to 5 year IDFS rate is between 70 to 80%. So we still are having 20 to 30% of patients having an IDFS event if they don't get a pCR. This is combining the RCB 1, 2, and 3 patients together. So again, quite a bit of risk persists in these patients. So how should we approach these patients with HER2-positive disease who have residual risks? And of course, our Catherine trial is a very big step forward for these patients. As has been pointed out, all patients were eligible except for the T1A and B and 0. So the T1C and 0 patients were eligible. Centrally confirmed HER2-positive disease on their upfront core biopsy. That's an important point. They had a minimum of 9 weeks of chemotherapy, and they could have had an anthracycline and a taxane, a minimum of 9 weeks of trastuzumab, and they could have had a second HER2-targeted agent as well. About 20% did have pertuzumab, and they could have residual disease in either their breast and or axilla. They had to be randomized within 12 weeks of surgery. And as you know, they were randomized to finish up their year of trastuzumab. Actually, they got 14 cycles, which takes 10 months, which takes 30 weeks, and or 40 weeks. And then the TDM1 also 14 cycles, and it is 10 months of therapy, 3.6 mg per kg IV every 3 weeks for 14 cycles. And we're very well aware that the data at the median follow-up of 8.4 years, 101 months, was really very striking. The curves kept pulling apart. It was 13.7 months absolute improvement in IDFS at 7 years, which was better than the 5 years and better than the 3 years, with a hazard ratio of around 0.5, highly statistically significantly positive. Still, at 7 years, 20% of patients still had an IDFS event. And what were those events? Well, we can see over on the far right, in terms of all IDFS events, 32% with trastuzumab, 19% with TDM1. With regard to distant recurrence, 21% with the trastuzumab and 14% with the TDM1. Unfortunately, there was no difference. The TDM1 did not decrease the risk of having a CNS recurrence as part of the first recurrence, either an isolated recurrence or as part of a recurrence otherwise systemically. So 7% with the TDM1 and 5% with the trastuzumab. The TDM1 also decreased local regional recurrence, contralateral breast cancer, no difference in death without a prior event. So very striking data, very important. And then, of course, the overall survival advantage. This turned positive here at the 7 years, a 4.7% absolute improvement in overall survival. And we can see again, the hazard is 0.66. And with this survival advantage, it is, I think, increasingly important to consider preoperative therapy for patients. And so if they're not a pCR, they can, in fact, they can benefit from the addition of the TDM1. Now, what if there's just a very small amount of residual disease in the breast, a T1A disease, or even just microscopic invasive disease, 1 millimeter or less, and that's what's shown here in the red box, and we see the hazard ratio still on 0.5. That was a group that also benefited. Of course, their absolute benefit would be less in this lower risk population, but there wasn't a group of patients with regard to size or nodal status who didn't benefit from the addition of the TDM1 in the Catherine trial. Now, what about if the disease, the residual disease, is negative, HER2 negative at the time of surgery? Now, remember, they were all centrally confirmed HER2 positive up front. This was a little less than 10% of patients whose residual disease was found to be HER2 negative. Now, in the solid lines, those are the patients who had they still had HER2 positive residual disease. And the blue is the TDM1, and the red is the trastuzumab, and we see that nice improvement. The dotted lines is a small number of patients who had their cancer was HER2 negative. And you can see on the top there with the TDM1, they did exceptionally well. There weren't any recurrences in that group versus the dotted lines in the red. So I think pretty persuasive that if patients really start off with HER2 positive breast cancer, we probably don't really need to know. We don't probably have to repeat the HER2 on their residual disease given these data, albeit a fairly small population. I did want to put in here the importance of getting the diagnosis right with regard to HER2 positive disease on that initial core biopsy. I think this is an area that we still struggle with in the clinic. These are the 2018 ASCO CAP guidelines, and we can see, for example, starting on the right in group 5, very clearly HER2 negative. The HER2 gene copies are less than 4, and the ratio HER2 CEP17 ratio is less than 2, clearly negative. And then on the right-hand side, we have the clearly positive. So we have HER2 gene copies more than 4 or more, and we have the ratio over 2. So those are quite clear, a little bit easier. But groups 2, 3, and 4 are really a gray zone here. In group 4, for example, the ratio is less than 2, but they have 4 to 6 HER2 gene copies. And in group 3, they have 6 or more HER2 gene copies. And then in group 2, the ratio is more than 2, but it's less than 4 HER2 gene copies. These oftentimes are an overcall, and if it's sent, the patient's cancer is sent out again to another reference laboratory, many times these come back negative. And you may recall, and I was looking at the most recent data, but it's still the fact that 5 to 20% of the time there's a discordance between locally assessed HER2 and centrally assessed HER2. I think this is very, very important these days, particularly because the therapy is just so different. If they're ER negative, HER2 negative, oftentimes they would get the KEYNOTE-522 regimen. And if they're HR positive, HER2 negative, they may be a candidate for an adjuvant CDK4/6 inhibitor. So this is an area that I find commonly is something I send out for the central reference laboratory quite frequently. So that's one way to cut down on our residual cancer burden, is by getting the diagnosis right in the first place and not treating patients with chemotherapy and HER2-directed therapy whose cancers are not really HER2 positive. So what about toxicities from the TDM1? There was hepatic toxicity, peripheral neuropathy, and thrombocytopenia. As you see there, any grade was about a third of patients for each. Fortunately, the grade 3, 4 events were really quite small. So this was actually quite well tolerated. I did want to point out down at the bottom there the rare hepatic nodular regenerative hyperplasia with non-cirrhotic portal hypertension. I've given a couple of references there. The median onset of about 300 days. And you can see on the bottom left there that in these patients that get the TDM1, and that's the rising curve there, we're looking at splenomegaly. And the median onset about 300 days or so, really showing this portal hypertension. And then we can see on the right-hand side, again, the number of days for developing this. So this is a rare phenomenon. If patients are having continued LFT abnormalities, it's probably worth looking into this and getting hepatology involved, because we certainly would want to stop the TDM1 if patients were developing any signs of portal hypertension. So were there any subsets of patients who did not benefit from TDM1 in the Catherine trial? And we can see on the left, PIK3CA mutation status. It's well corroborated that PIK3CA mutations predict for a lower rate of pathologic complete response in HER2-positive breast cancer, but it made no difference with regard to benefit from TDM1. As you see, those curves are on top of each other. And then on the right, with regard to intrinsic subtype, we see in panel B with the trastuzumab, down the bottom in the yellow is the, here we go, is the basal-like. This is the HER2 enriched. And then these are luminal A and luminal B. Here we can see with the trastuzumab, the HER2 enriched and the basal-like are doing very poorly. All boats rose here with using the TDM1. Still, the basal-like still had a poor prognosis, but all patients, all of the intrinsic subtypes did better with the TDM1 compared with trastuzumab. Other biomarkers were looked at here, and suffice it to say, there really wasn't a subset of patients who didn't benefit from the TDM1, including those who had had the antecedent pertuzumab. I did want to point out here in this box that if patients had HER2 3+, they had a hazard ratio of 0.5 for their IDFS, and patients that were 2+, again, they were FISH positive, they had lesser benefit from the TDM1. TDM1 does not have a bystander effect. There has to be enough HER2 expression on the cell surface for enough drug to be internalized and the payload released. So there is not a bystander effect for neighboring cells that have less HER2. And that's also shown down here, just looking at intratumoral heterogeneity. If patients had less than 30% of their cancer cells with HER2 expression, they did not benefit here. Now, these are overlapping confidence intervals in small numbers, et cetera, but basically patients who, as long as they had 70% or more of their cells positive, they did benefit from the TDM1. So can we then improve upon Catherine? It's a big advance, but still at the 7-year mark for the node-positive patients, 72% had had an IDFS event, no improvement in the rates of CNS recurrence. And so what considerations do we have for further escalation of treatment in these patients? Well, one thing is that we really need to optimize the endocrine therapy for patients with HER2-positive, HR-positive breast cancer. Our postmenopausal women, they're going to get an aromatase inhibitor, but what about our premenopausal women? So Catherine was enrolled between 2013 and 2015. The soft and the text results using an LHRH agonist in premenopausal women, which showed improvement in outcome, both with tamoxifen and with an aromatase inhibitor, was published in 2014. The actual endocrine therapy the patients received in the Catherine trial is not reported in the trial, but I would imagine that the endocrine therapy was probably not fully optimal for patients in the Catherine trial. This is an exploratory analysis from the HERA trial. The HERA trial was an adjuvant trial of trastuzumab. Patients had finished up their chemotherapy, and they were randomized to no trastuzumab versus 1 year versus 2 years. And this is a exploratory retrospective analysis of the outcome of the premenopausal patients who received tamoxifen or ovarian function suppression plus endocrine therapy. And here is ovarian function suppression, tamoxifen, versus ovarian function suppression plus an aromatase inhibitor. And these are big improvements in outcomes. So I think it really does behoove us to optimize endocrine therapy for these patients, and that would be the OFS AI for most patients. What about adding neratinib? You know, the pan-HER inhibitor inhibits HER1 and HER2 quite well, inhibits HER4. It escapes the cancer escaping through HER3. And so neratinib is an oral tyrosine kinase inhibitor. And in the ExteNet trial, this trial took place before pertuzumab and T-DM1 became the standard of care. So patients had received their chemotherapy and their trastuzumab. They had to finish up their adjuvant trastuzumab, and they were randomized to 1 year of neratinib, 240 milligrams daily, versus placebo. And the primary endpoint of the trial was 2-year invasive disease-free survival, but there was extended follow-up looking at 5-year invasive disease-free survival. So looking at the intent to treat population here at 5 years, putting together both the HR positive and the HR negative, we see a hazard ratio of 0.73 and a 2.5% absolute improvement in IDFS at 5 years, no difference in overall survival. When you look at the forest plot, the subset analyses, what stood out are the two things in these boxes here. So in the HR positive patients, the hazard ratio was a 0.6 as opposed to 0.95 in the HR negative population. And also, patients could have enrolled in the randomization up to 2 years after finishing their adjuvant trastuzumab, but it was only those who were randomized within a year of finishing their adjuvant trastuzumab who benefited. So this is the EMA label for neratinib, is in the HR positive population who had finished their trastuzumab within a year. The FDA approved the intent to treat population. So an exploratory analysis was done on the 295 patients in the ExteNet study who received their chemotherapy and trastuzumab preoperatively and then finished up their trastuzumab in the adjuvant setting. So if we look at this population that benefited from the neratinib, the HR positive group that had been randomized within a year of finishing their trastuzumab, we see an improvement of 7.4% in IDFS at 5 years, and we see an improvement in survival of 9.1%. So these are encouraging, again, limited by the fact that this trial was done before we had pertuzumab and before we had T-DM1. Nonetheless, these are big improvements in this HR-positive population, which, as we saw, if they're RCB 2 and 3, they have a very poor prognosis. So I think this is an option for those patients. Also looked at in the ExteNet study, again, looking at the HR-positive population who were randomized within a year of finishing their adjuvant trastuzumab, 1,334 patients, was cumulative incidence of CNS recurrence at 5 years with the neratinib and placebo. So, for example, if we look down here at patients who did not have a pCR, and that was most of the patients, the 295 who went on to the ExteNet, there was only a few who had a pCR, we see a 3.6% risk of having a CNS event. And these were, again, just clinically manifest, not surveyed, and versus 0.8%. And the 5-year CNS PFS was 98% versus 92%. So clearly a signal of benefit with regard to reducing the risk of CNS recurrence. Clearly, we are very interested in doing better in our HER2-positive patients. With regard to CNS metastasis, we have two very promising candidates. We have tucatinib, as has been shown in the HER2 CLIMB trial, in combination, tucatinib with capecitabine and trastuzumab, where the CNS response rate was 47%. At 12 months, 35% of patients were progression-free in their CNS. And then recently, we saw the data, 106 patients in the DESTINY-Breast12 trial. This was a phase 2 trial, and these are 67 patients who had treated and progressing brain mets and 39 patients who were untreated for their brain mets. We see the response rates here of 82% and 50% in the CNS, and at 12 months, 60% of the patients were still progression-free. So these are really striking improvements in the brain, just a great deal of activity against brain metastasis, very, very encouraging. And so we've seen this schema before. This is the COMPASS HER2 trial, stage 2 and 3 patients, HER2 positive, and they get 4 cycles of THP, either paclitaxel or docetaxel with trastuzumab, pertuzumab, and it is estimated that about 40% will have a pathologic complete response with just this amount of therapy, and then they go on to finish up their year of HP, of course, with endocrine therapy if they're ER positive. For the estimated 60% who don't have a path CR, these patients are randomized to TDM1 for 14 doses or TDM1 tucatinib. They can go on to get additional therapy before this randomization. So this will hopefully improve upon the Catherine trial with regard to IDFS and also cut down on the risk of CNS recurrence in this high-risk group that does not have a path CR. So the other strategy, of course, in the high-risk adjuvant setting is TDXD and trastuzumab deruxtecan. We're very familiar now with the DESTINY-Breast03 trial in the second-line setting, that head-to-head comparison of TDXD versus TDM1 with this very striking improvement in progression-free survival with a median of almost 29 months of progression-free survival with TDXD. Very striking also survival advantage in these patients. And so, of course, very natural to get it into the adjuvant setting as soon as possible. And this was a high-risk population. These patients had had their preoperative chemotherapy, trastuzumab, with or without pertuzumab. And in the residual disease group, they had to have been either inoperable at presentation or have residual disease that was node positive. So a higher risk, enriching for a higher risk group that did not have a path CR, randomized to the TDM1 versus TDXD. And hopefully we'll see the results of this trial next year. Very, very important. And then, as we've heard with the DESTINY-Breast11, of course, another strategy is to just cut down on the percentage of patients who end up with without having a pathologic complete response. And this is the DESTINY-Breast11, which we hopefully will also see next year. This arm A has been closed, the 8 cycles of the TDXD preoperatively, stage 2 and 3 patients, versus 4 cycles of TDXD, followed by the paclitaxel, trastuzumab, and pertuzumab for 4 cycles, versus the TCHP, the standard of care TCHP. ACTHP here. So a standard arm versus 4 cycles of TDXD followed by the THP here. So very, very interesting strategy, seeing if the TDXD could potentially, obviate the need for an anthracycline-based regimen. Another trial that's going on in patients who have residual disease after their preoperative chemotherapy and HER2-directed therapy, or who are very high risk to begin with, such as stage 3 disease, but they have a path CR, but they were very high risk. We know about 10 to 15% of those patients, even with a path CR, can go on to recur. And this is the Flamingo trial. And patients have finished their adjuvant trastuzumab-based therapy now, and they are randomized to receive this peptide, this HER2 peptide of an immunogenic epitope called GP2 with GM-CSF, and they're randomized if they have the HLA-O2 genotype, then they are randomized to this vaccine, the GP2 GM-CSF, for 6 doses monthly and then 5 doses every 6 months, and then versus placebo. And then if they do not have the HLA-O2, then there's an arm of just getting the vaccine. So this is enrolling well. It still has about another year to go of enrollment. This was based on a study that was done in San Antonio some years back now, where 100% of patients had, at the 5-year mark, 46 HER2 3+ positive patients who were treated with the vaccine with GM-CSF after adjuvant trastuzumab, and there were no recurrences in this group. And that's what led to the further development of this vaccine strategy. So where may we be headed now in the future? Of course, we would like to be able to identify patients at risk for residual disease up front. We'd like to have biomarkers to be able to ascertain who is going to need more optimized therapy for their high-risk status. And we've heard about the HER2 DX risk score, and this is a risk score that is an algorithm of proliferation, immune signaling, luminal differentiation, and HER2 amplicon, also HER2 RNA expression as well. And patients who have a low-risk HER2 DX score, and this is a meta-analysis, now an individual patient-level meta-analysis of 7 cohorts. The trials are shown down here. And these patients who have the HER2 DX low-risk score, they do very well. And those who have a high-risk score do more poorly. So this would be very helpful to be able to identify both of these groups up front and to be able to optimize their therapy. There is a separate score, the HER2 DX pCR score, and this looks here at the high-risk patients, the intermediate risk patients, or high. This is high for pCR, low for low chance of having a pCR, high chance and intermediate risk here. And this is looking at single versus dual HER2 blockade. And then this over here, same 3 groups, is looking at single agent chemotherapy versus multi-agent chemotherapy. And we see these patients who are called out as having a low risk, a low chance of a pCR. This is true. This really became the case. Very small amounts, and adding more HER2-directed therapy, adding more chemotherapy did not make a difference for these patients. And so that is a group that could be studied separately. Whereas the patients who have a high chance of getting a pCR, then adding more chemotherapy, they did very well. Adding more chemotherapy did not make a difference. However, adding dual HER2 blockade made a difference for these patients. So these are very, very interesting data that have now led to the conduct of the HER2 DX definitive trial that is going on with the principal investigators shown down here. We have 300 plus patients who undergo the HER2 DX score. And there's a group of patients who are getting a standard of care. But the patients who have the HER2 DX score done, they get, if they're HER2 low risk, they just go on to THP. But if they're HER2 high risk, then there's 3 different cohorts: high risk, intermediate risk, and low risk for getting a pCR, and their therapies are apportioned accordingly. So the patients that have a high chance, they get the THP. Intermediate risk, they get TCHP, and then those who have a low risk is physicians, low chance of getting a pCR, that's physician's choice. So this is a way really to use both the HER2 risk score as well as the HER2 pCR score to try to optimize patients' therapy. So very good. So is the presence of residual disease the best way to identify patients at high risk of relapse after preoperative therapy? Could we use ctDNA to adapt their therapy, either tumor-informed or tumor non-informed? Patients would be getting preoperative therapy, going to surgery, and they can be monitored with ctDNA at diagnosis, prior to surgery, following surgery, and then, of course, surveillance. And these are just some data shared by Mark Magbanawa from the I-SPY group, showing here in the HER2 positive patients that, and this is, they've finished up their neoadjuvant chemotherapy, and before they went to surgery, they had ctDNA assessed, and then at surgery, their pCR status was assessed. And you can see up at the top here in the green and the blue, the patients who's had ctDNA negativity did extremely well, and that was actually regardless of whether they had a pCR or not, suggesting that ctDNA may even be a better marker of outcome than our residual disease status. Those who still had, ctDNA positivity prior to surgery did very poorly, and they did very poorly very quickly. These are very small numbers. We'll wait to see more patients from the I-SPY. But this really is quite provocative. We could assess, before they go to surgery, we could assess ctDNA. If they're positive, the job is not done, and we could then optimize therapy and escalate their therapy. So in conclusion, residual disease after HER2-directed neoadjuvant therapy confers increased risk of recurrence proportional to the residual cancer burden. About 5 to 20% discordance in HER2 results on that upfront core biopsy between local and central laboratory. I think this remains a very challenging issue, HER2 testing. And if we have any uncertainty about it, we really need to confirm that diagnosis in a central reference laboratory. TDM1 substantially improves invasive disease-free survival and overall survival in patients with residual disease, but brain micrometastasis and disease with lower HER2 expression may not be eradicated fully with the TDM1. It's super critical to optimize endocrine therapy in our higher risk premenopausal patients with an LHRH agonist and an aromatase inhibitor. We hope that tucatinib and TDXD may address some of the unmet need that we still have. And in terms of identifying and enriching trials for patients who are high risk of having that residual disease, looking promising, the HER2-DX, ctDNA, stromal TIL, and also the preoperative HP with PET imaging. These are all quite promising strategies. So I will just finish. I won't take time here, but I just wanted to, I put the NCCN guidelines in the slide deck. Thank you very much.
Okay, good. Thank you very much to you all for your great talks. We have 20 minutes for discussion. We have plenty of questions. So, Beth, just feel free to interrupt us at any time. May you make any comment before starting the discussion? Any thoughts?
Sure. Is this on? Yes, it is. This is all very interesting to me because 16 years ago, this month, I was finishing up neoadjuvant chemotherapy and Herceptin after a stage 3 HER2-positive breast cancer diagnosis. And then they threw, and I had a pathologically complete response, and then they threw the book at me with continued Herceptin and 6 weeks at that time of radiation therapy. And so much terrific stuff has happened since then, but I'm left with the concept that we spent a lot of time talking about these percentages. I like to look at absolute risk, not percentage differences, because I think the absolute risk is the key one, and we don't do that. But the other thing that was missing from a lot of this was overall survival. We sort of moved to progression-free survival, and I worry that the overall survival is getting lost, and there is importance in that. And the other thing that I didn't hear a lot talked about were patient-reported outcomes. And the reality is an extra 6 months of life and you feel like crap and you have no hair is very different than an extra 3 months of life where you actually have some quality of life. And so the question, there was a little bit of quality of life in here, but how do we get more focus on patient-reported outcomes in these trials? And importantly, how do we ensure that the patients really understand the implications of these different treatment options? Because I'm a graduate of IBCC Project Lead Institute, and I've also mentored there, so I've gone through it several times, and I'm overwhelmed with all this stuff. I can't imagine what most patients would do. That's why we believe trained advocates need to be at every stage of the planning of trials and then there to help interpret with people. So what's going on with patient-reported outcomes?
I just want to make the comment, first of all, so thrilled that you're cured of the HER2-positive breast cancer, just absolutely phenomenal. I think your points bring to mind the importance of stratifying our patients by risk, because if they have a high chance of having a cure anyway, and the difference between treatment A and treatment B is very, very minimal, we need to identify those patients because the quality of life will depend on how much therapy they have to have, basically. Conversely, patients who have HER2-DX high risk, for example, a low chance of having a pCR, these are patients that we just need to escalate. It's just, it really gets to the point where I think we really are going, But there were some patient-reported outcome data in some of the trials. I just didn't go over them, but there's some. But I think we really have to identify patients at both ends of that spectrum and really optimize their therapy.
Well, and I also think that in discussing outcomes, I mean, there's a big difference between when you have women who are presented with, breast cancer diagnosis, it's sort of like, lop them off, I don't need them, I just want to live. But in fact, there's not a real discussion of the implications of losing a breast and the impact that has on things like sex life and other things versus breast-conserving surgery and all of that. So it's getting people to understand what the risks are, I think, is really important. And the other thing that we haven't talked about is the financial toxicity, because this is great that there's all this stuff here, but my recollection from last year is these new therapies are incredibly expensive. And so then you have a situation where, if insurance is not covering it, and a lot of times it doesn't, how do you make treatment choices when you can't get access to the drug? And what do we do about the rest of the world where, in New Zealand, they're still trying to figure out how to get full access to things like, I think, even Herceptin. I don't hear us talking about that. We talk about all of these great bells and whistles, but not how we're really going to get the treatment to people.
I think that the financial toxicity question is incredibly important in all stages and subtypes of breast cancer, of course, but, it rings particularly true, and I'm so glad you raised it for patients with HER2-positive breast cancer. This is my opinion. I'm curious if you agree with me, because, at this point, you walk in the door with a HER2-positive breast cancer. It doesn't matter if it's teensy tiny or it's stage 3 with residual disease. You're basically looking at 12 to 18 months of some sort of therapy that's administered in an infusion center. It might be more intensive or less intensive, but you're going to the cancer center to get it. And I think I think it's an incredibly important point, especially in HER2-positive disease, to think about the implications that has on patients' lives, not just in terms of hair loss and side effects, but in terms of ability to work and co-pays for extra pills we had, and the time toxicity measure of time spent away from home, spent away from loved ones, spent away from doing what you want to be doing. So to me, again, I'd be curious if you agree that just feels especially important for HER2-positive patients.
And by the way, I would like to think I'm cured, but the NBCC position is no evidence of disease, and our founder, Fran Visco, recurred after 38 years. So, but it wasn't HER2. Well, we don't know what it was, but it's ER positive now.
Maybe I would like to add that, considering the design of the trials, I think it's hugely important to have patients involved in all settings. That's for one. And I think we've also learned about how we design trials in the past. For instance, the 12 or even 24 months of trastuzumab that we've been using, the 12 months at least. And even now, if you have large meta-analysis presented that 6 months is as good as 12 months, we're still very reluctant to change our regimens. So I think it's hugely important to think the duration of the treatments that we're giving in these trials. What do we do? 14 cycles of TDM1? Why was it 14 cycles of TDM1? Was 6 cycles good enough? Could we have 6 and 14 to compare with? I think things like that will not be easily done in the trials if it's left to maybe the PIs, maybe the industry. And I think patient focus is hugely important to have these aspects in the trials.
Okay, so we have only 12 minutes left and so many questions here that I would like to ask you, and be very brief, please, because I have at least 14 or 15 important questions for the clinical practice. I will start with the classical one, anthracyclines. You have said that maybe not anthracyclines now in the future, but let me complain a little bit. BCIRG006, TCH, or ACTH, we cannot compare both, but there is about 2 to 3% absolute benefit along the curves all the time in favor of ACTH. TRAIN 2. In the control arm, they gave 9
cycles of TCHP, which is not a standard of care. So my question is, if you decide not to give anthracyclines based on train 2, do you mean that we have to give 9 cycles of TCHP? Because if you give 6 TCHP, what is based on? Question? Quick answer. All of you. All of you.
BCRG 006. BCRG 006, ACTH versus TCH. It wasn't with P, but those were equivalent at the 10-year mark. There was a little separation of the curve, but that was another anthracycline versus non-anthracycline TCH, just as good. So that's reassuring to me as well.
Okay, I would like to ask the audience for a minute. Could you please raise your hands? Who of you are still using anthracyclines for a significant number of patients with HER2 positive early breast cancer? Okay, and the other way around, who does not? The majority. We lost. Any comments?
Well, I think the totality of the data, it's not the BCRG6 or the train 9 cycles, it's the totality of the data. There are so many trials now showing excellent responses and outcomes without anthracyclines, and time and again showing the toxicity of the anthracyclines that I think I can understand why the majority is not using them.
Okay, good. Second question. So, APT, you said, I think it was you, well, any of you, I don't remember. You said in PT1B, APT strategy, in the ATTEMPT study, it has been compared TDM1 followed by trastuzumab versus TH. My question is, why not TDM1 if we have similar data with better toxicity profile?
You're saying why not use TDM1 for a year
Correct.
for the patients in the sort of smaller, the less than or equal to a centimeter, the T1B size range? Is that what you mean? I think that's an absolutely reasonable thing to do personally. I do present the ATTEMPT regimen, the full year of TDM1, to many of my patients, especially in the smaller size ranges, with alongside the TH regimen. But I do think we then have to follow that up with the fact that, in the way that we compared, the reason to do TDM1 would be to save some toxicity. In the way that those were compared in the ATTEMPT trial, the year of TDM1, full year of TDM1, actually wasn't the winner, at least in the way that it was measured. But for women, again, who are premenopausal and maintaining menses is extremely important. Women who have pre-existing neuropathy you're worried about, and women who are really worried about alopecia, I think it's a very reasonable option, actually, even for T1C.
Let's go to the clinical practice, and the pathologist says to you, this HER2 positive tumor has a significant intratumor heterogeneity. Any comments?
I mean, I didn't answer the anthracycline question, so I'll just add there that that is a subset where I really agree with what Dr. Sonke put up on the slide, that if you're really uncertain if it's a HER2 positive tumor or there's significant heterogeneity there, that is a place where I would strongly consider a regimen like ACTHP in the neoadjuvant setting, because that then you're using a standard backbone that works for more of a triple negative or an ER positive HER2 negative patient.
Good. More questions.
Fully agree.
More questions. Clinical practice. You go to the clinic, you visit a patient, and you have a 15-millimeter tumor. So the question is, neoadjuvant or upfront surgery? Is the size of the tumor the only marker or the only aspect to be considered when we are going to design the best primary approach?
I think that that's right. That's the borderline there. And I think that, because Catherine enrolled those patients that were T1C and 0, that's the strongest argument to give the patients preoperative therapy. So I don't think we really have good data to say that there are other biologic characteristics that would help us decide that the patient's going to do really, really well and they're not going to need TDM1. I don't think we have that information. So I really couldn't say that just besides the Catherine results.
Okay, so microphone 2, microphone 4, and microphone whatever. You first.
I'm Dr. Mohammed Shibeli from Saudi Arabia. Thank you all for the great presentation and discussion. My question about some category of patients who are stage 1C and who are HER2 positive and germline BRCA positive. Do you think that the presence of germline BRCA positive will change the decision of management regarding de-escalation versus escalation of treatment? And my second question, is there any data for combining or sequencing PARP inhibitors with anti-HER2 in the adjuvant setting in patients with the BRCA positive?
So I think for the second question, at least in our setting, the adjuvant PARP inhibitors are not registered for the HER2 positive disease. So I think that's a fairly easy question from a practical point of view. Whether you should keep BRCA status in your decision rule, I'm not so sure. I would definitely be interested to hear our pathologist whether this is not a heterogeneous tumor. If not, I don't think the BRCA status itself conveys a poor prognosis. So I think I treat them similarly. One question we typically get is if it's a small tumor, you need to add carboplatin because probably the BRCA phenotype might be more sensitive. At the same time, these small tumors, I think that's really a lot of overtreatment, and I would refrain from that, I think.
Okay, microphone 3.
So I'm Ashwini Bhatt. I'm from Baylor, Scotland, right from Central Texas. So I'm a medical oncologist. So I have a 46-year-old patient diagnosed with DCIS. Initially, she underwent bilateral mastectomy. So the final path said 6.5 centimeters of DCIS, but there was a 3 millimeter invasive cancer, but it was considered a T4 lesion because it had dermal invasion with ulceration. This was also sent to MD Anderson for path review, and they agreed with the T4 diagnosis. She was node negative, margins negative. She was grade 3, Ki67 of 70%, ER negative, PR negative. So what would you consider as a good adjuvant therapy? TH, TCH, TCPH, no adjuvant therapy? And the second question would be radiation or no radiation, because the DCIS was close.
And she was node negative, you said?
Node negative, 3 nodes negative.
Mm-hmm. Well, I think TCH would be a very good standard for her. I would treat her as though she were higher risk, I think, based on that lymphatic invasion, skin involvement, et cetera. And with margins close, I probably would consider radiation therapy for her. I think we've all seen HER2 disease come back on the chest wall. It can be quite persistent and invasive. So I would, with that particular skin involvement and lymphatic invasion, I would treat her pretty straightforwardly for a node-negative patient in the adjuvant setting.
Thank you.
Microphone 4.
Hi, Bill Sykoff from Brown University. Ada and Joyce, I wasn't going to say anything, but I have to strongly disagree with your recommendation that you give a patient with a clinical T1CN0 cancer neoadjuvant chemotherapy and HER2-targeted therapy so that you can give them TDM1 in the adjuvant setting. If you had taken that person to surgery first, and unless you found nodal involvement or something else unexpected, you would be very happy to give them TH and say, you've got a 95+% likelihood of being free of disease. I don't like to punish my patients for getting neoadjuvant therapy. I say to them, especially if they were ER positive, HER2 positive, they only have a 50% likelihood of getting a pathologic complete response, but those patients still have a 95+% likelihood of disease-free survival, 98+% distant disease-free survival. So I do give neoadjuvant therapy to some of my patients with HER2 positive, small HER2 positive cancers. If the surgeon says to me, well, if you make it a little bit smaller, I can do better in terms of their cosmetic outcome. But I would never give a patient with T1CN0 disease adjuvant TDM1 just because they failed to achieve a pathologic complete response, because I know that their outcomes are going to be so good.
Hi, Bill. Thank you.
Hi, Ada.
Just to be clear, I certainly would not, across the board, recommend giving neoadjuvant therapy to the large majority of patients with clinical T1C and 0 tumors. That's definitely not what I intended to recommend. So just to be clear about that, in my personal practice, I agree with you. As long as I can be as convinced as I possibly can with an axillary ultrasound and, without calcifications that are spanning 2.5 centimeters and I'm not sure what they are, et cetera, I will take that patient to have them go to upfront surgery as long as downstaging them wouldn't change their surgical outcome or their surgical options. So I fully agree with you. But I do think there are selected cases where you have legitimate uncertainty. It's a young patient where you're way less worried about toxicity, where I would give them a neoadjuvant regimen. I would give them THP because we know that P improves PCR rates, probably not long-term outcomes. And I would give them, if they had residual disease, probably TDM1, because they were eligible for Catherine. But I hear you. But that wouldn't be my approach for the large majority of patients.
If I tell you that some patients with T1B are treated with neoadjuvant setting in my center, you are going to kill me. Just last question.
Wait. One last thing. I also have to give a plug for the NRG-BR008 study, the HERO trial, for patients who have, T1 N0 disease, whether they go to primary surgery or go to neoadjuvant therapy, get a pathologic complete response, to randomize them between standard radiation, breast irradiation, breast conserving surgery, versus omission of that. I want to put a plug in for what I think is a very useful study. Thank you.
Very last question. Eric, microphone 1.
So Bill made my life a little bit easier. I think that it's a slippery slope with T1C tumors. And we know that the outcome, if you have a T1C N0 tumor, is extraordinarily favorable. So in that setting, my fear is that someone gives neoadjuvant therapy, and as Bill said, and as Ada said she wouldn't do, but other people would do, that person is found to have residual disease and winds up getting more therapy that we now know is almost certainly unnecessary.
How do we know that, Eric? How do we know it's unnecessary if they have residual disease?
How do I know that? Because I know for certain that there were patients treated on APT and ATTEMPT who didn't have a PathCR. We didn't have 800 patients with PathCRs there. And yet, in spite of that, the outcome was unbelievably favorable with the number of distant recurrences in each study that can be counted on essentially one hand.
Those trials were adjuvant trials, right?
They absolutely were. And unlike the triple negative setting, where I think legitimately we have a concern about the effectiveness of immunotherapy postoperatively, this is a situation where if you found out someone had a positive lymph node, you could then make up for it with your treatment afterwards. You can give pertuzumab for a year if you want. You can do a variety of other things. So I just think that while there may be cases, exceptional cases, as Ada mentioned, where you want to give upfront therapy, just be careful of that slippery slope and be cautious about what you do once you have the surgical result.
And the NCCN endorses 1.5 centimeters and above as a benchmark for neoadjuvant therapy. So between the 1 centimeter and the 1.5, you can individualize. But giving
Joyce, just one sec. That came from thin air. There's no trial that has ever differentiated between someone with a 1.4 and a 1.6 centimeter tumor.
Yeah, but the 23% node positivity with the T1C was a little concerning. The thing is that if you give 4 cycles of THP preoperatively and then do an MRI and it's clear, you can go to surgery. You can de-escalate the amount of therapy people have and go to surgery. So that's about what they would get. They would get the pertuzumab and preoperatively that they may not get, but that doesn't add a lot of toxicity for the patients. It's just that we really don't know the nodal status in these T1C patients, and there's 23% that are going to be positive there. So, I think you can individualize for patients, but I think that, I pretty routinely, 1.5 and above, would give neoadjuvant therapy, and generally, I'm looking to try to only give 4 cycles of therapy. If I can get it to go away clinically and radiologically, I'll go to surgery.
So, dear friends, dear colleagues, dear Beth, so 14 more questions here, not being able to be answered. Apologize for that. It was totally my fault. Thank you very much to you all. Thank you very much for being here. And clearly, this is a great debate. Thank you.